All right, here we are back with part 2 of chapter 38 in orthopedic trauma. If you'll recall, we finished up part 1. We just started talking about some of the management of orthopedic trauma injuries, and that's where we're going to pick up here, and then we'll move on into some more specific types of orthopedic traumas that you may encounter out in the field. So here we'll pick right up with splinting. Of course, remember the main purpose of splinting is to provide support and prevent movement of those broken bone ends. This is going to help reduce pain, the risk of further damage to muscles, nerves, and especially blood vessels, as well as it can help to control bleeding and allow for clots to form. You can use a vacuum mattress or a scoop stretcher to stabilize the patient with multiple fractures, especially when their condition is extremely critical. These devices will protect against spinal injury. They'll reduce movement of injured extremities by securing them to the board, and then that can save you some time at the scene as well. Before you apply a splint, make sure that you can adequately see the entire injured area. You must assess and record the distal pulses, the motor movement, and sensory function, both before and after you apply that splint. Cover all wounds with sterile dressings before applying a splint. For open fractures, brush away any obvious debris that can be removed, but don't probe the wound or try to push the bone back in and under the skin. Don't move the patient before you splint them unless the conditions are hazardous and it is absolutely necessary to do so. And for fractures, you must also immobilize the bone ends at the two adjacent joints, so above and below. For dislocations, splint along the entire length of the bone above and below the joint. Make sure you pad the splint well and support the injury to minimize movement while you're applying that splint. If a long bone fracture is severely angulated, you can use longitudinal traction to realign the bone and improve circulation, but never attempt to straighten a fracture involving a joint without first getting some sort of medical direction. If the patient can tolerate it, splint the knees straight unless they are angulated and the elbows at a right angle. You must immediately stop applying traction if the patient reports any kind of severe pain. You should always apply a splint firmly, but not so tight that it cuts off circulation. Avoid covering the patient's fingers and toes. This is so you can continue to monitor circulatory compromise. After splinting, apply cold packs and elevate the limb to help reduce swelling. In cases of life-threatening injuries, splinting should never delay transport to the hospital. Now, there's a few types of splints that we can use, and the first one we're going to talk about is a rigid splint. This is simply an inflexible device that you can attach to a limb to provide stability. You must pad the splint generously to ensure that there's even pressure applied along the extremity. The splint also needs to be long enough to secure both above and below the fracture site. Applying a rigid splint requires two providers typically, one to maintain traction on the limb and the other to wrap the splint or to place the splint and kind of secure it in place. A sling is another very useful tool at stabilizing injuries, especially to the shoulder and other parts of upper extremities. You should also review the correct technique for applying a sling, and there's a couple of different ways that you can do that. Some of them are very simple, some of them are more complex, and it's going to be just different depending upon what you're needing, what that needs. It's also helpful sometimes if you've got a more slender pillow to kind of tuck that up underneath that extremity to provide some support. It takes a little bit of pressure off of the neck, and it can sometimes help alleviate some pain if they're having some discomfort in their neck. Pneumatic splints are used to stabilize fractures of the lower leg and forearm. You should not use them for angulated fractures that involve a joint, or open fractures. There are two main advantages that they can help to slow bleeding and help minimize swelling. A change in temperature can affect the splint's pressure though. So if the splint is applied in a cold area, the patient is moved to a warmer one, it can either lose pressure or overinflate, and which could lead to some circulatory problems. So that's why it's important to reassess, especially when you're using pneumatic splints and you go from extreme temperature climates. A vacuum splint, on the other hand, is a sealed plastic container filled with thousands of little small plastic beads that you wrap and form around the limb. A suction pump is then attached to the splint to remove all the air from inside, which causes the splint to become rigid and stable. Smaller versions are also available for stabilizing individual limbs. These work well, especially for those angulated fractures and those kinds of things that a traditional rigid splint wouldn't be useful for. A vacuum mattress is a type of vacuum splint that is used as a mattress underneath the patient. It gives excellent stabilization for the patient's spine and any other extremities on the mattress. A major disadvantage, though, is that it can be bulky and take up a lot of space in your vehicle, and if it gets punctured, it very quickly loses its usefulness. Traction splints are used to stabilize femur fractures by applying constant pull on the bone. The splint prevents the bone ends from overlapping due to muscle contraction. It maintains alignment, provides effective stabilization, and reduces blood loss. You should not use a traction splint if there is another fracture below the knee on the same leg, though. It's important to review the proper technique for applying a traction splint. You should be cautious with prolonged use of traction splints, especially during long transports of 2 hours or more, because over-tensioning can cause nerve damage or pressure sores on the patient. Remember to reassess the patient's pulse movement and sensation after applying a traction splint. Buddy splinting is a technique used for injuries to the fingers and toes where an adjacent digit acts like a splint. To perform this, you just simply tape the injured digit to the uninjured one, making sure to place gauze between the two of them. You should avoid taping over joints to ensure that the tape is not so tight that it cuts off circulation, because the blood vessels are going to run much closer to the surface of the skin at the joint area, especially in digits. All right, so let's get into talking about some pathophysiology and management of some very specific musculoskeletal injuries. And this is going to be the bulk of where we're going to spend our time for the remainder of this section and into the next section. The likelihood of complications from musculoskeletal injuries directly related to three main factors: the strength of the force that caused the injury, the location of the injury, and of course the patient's overall health. Long-term disability is one of the most difficult consequences of musculoskeletal injuries. As a paramedic, you can help reduce the probability of long-term disability by preventing further injury, reducing the risk of infection, and minimizing patients' pain, as well as transporting them to the most appropriate facility that it is able to manage their type of injury. Devascularization happens when a musculoskeletal injury damages the blood vessels, leading to a loss of blood flow to the body part that vessel supplied. A fracture of the shoulder girdle or upper arm can lead to a neurological deficit because displaced bone fragments can impale or damage nerves of the plexus. Peripheral nerve injuries are a likely complication of joint dislocations, especially those in the knee. So you must perform a thorough neurological exam to identify which nerve is affected and where the injury has occurred along its path. Splinting the injury in an anatomic position can help relieve pressure on the nerve. So that's why it's recommended that you try to get that limb back into an anatomical position whenever possible. However, if that is not possible, it's important to not over manipulate those areas where those nerves run so close to the surface, and that's especially where we see at the joints. Fascia is an inelastic membrane that surrounds groups of muscles in a limb. When bleeding or swelling occurs in this enclosed space, the pressure begins to build up, leading to a condition called compartment syndrome. The causes of compartment syndrome can be overly tight application can be caused by an overly tight application of bandages or splints or even casts. It can also be caused by bleeding within a compartment due to a fracture, crush injury, vascular injuries, or even something like a snake bite. Lastly, it can be caused by fluid leakage or just general swelling into that particular area. The first sign of compartment syndrome is a complaint of searing or burning pain in the affected area, which is often severe and not relieved by pain medication. The affected area may also feel firm and the skin might be pale. Neurologic symptoms are going to include paresthesis, that tingling or prickling sensation, and the paralysis of the involved muscles. Pulselessness is a very late sign, and by the time you see it, significant muscle death and potentially nerve damage has already occurred. A patient can still have compartment syndrome even if you feel a peripheral pulse. Your primary goal in managing these is to deliver the patient to an emergency facility before they become pulseless. To manage the condition, you should elevate the extremity to the heart level and apply cold packs. You also need to open or loosen any clothing or splinting material that may be constricting the limb. Finally, you should administer a bolus of isotonic crystalloid solution. Crush syndrome, on the other hand, this occurs when a prolonged compression force impairs circulation and causes muscle tissue to become ischemic and die. This releases harmful products into the bloodstream. This is often seen in patients when a patient has been lying on an extremity for an extended period, but it can also be caused by excessive exertion, infection, or certain medical conditions and medications. After about 4 to 6 hours, the compressed muscle begins to die and release substances like lactate, potassium, myoglobin, all of which can decrease the pH of the blood. The most serious complication is renal failure, which can occur once the crushing force is released. The large amount of myoglobin released can clog the small tubes of the kidneys that filter the blood and render them ineffective. This dysfunction can then further lead to serious electrolyte abnormalities such as hyperkalemia, which can cause cardiac dysrhythmias and significant EKG changes. Any treatment for crush syndrome should always be performed with medical direction. Before releasing the crush force, you must first assess the patient's ABCs. You should also administer high-flow supplemental oxygen and a bolus of crystalloid solution. Finally, establish cardiac monitoring and evaluate EKG changes relative to hypokalemia or high potassium levels. Be sure to consult with medical control before releasing your limb after a prolonged crush event. En route to the hospital, complete a rapid full body scan and provide care for any injuries you were unable to treat at the scene. Thrombolytic disease is a significant cause of death after musculoskeletal injuries, including things like deep vein thrombosis or pulmonary embolisms. These conditions occur more frequently with injuries that require prolonged immobilization. The signs and symptoms of deep vein thrombosis include disproportionate swelling, discomfort in the extremity that worsens with use, and this is where you'll see that classical warmth and redness to that extremity. A pulmonary embolism, on the other hand, is a blood clot that blocks a portion or all of the arteries leading to the lungs. The signs and symptoms of pulmonary embolism can have a sudden onset of shortness of breath, maybe some chest pain that worsens with a deep breath, and rapid breathing. The patient may also have a rapid heart rate, low-grade fever, right-sided heart failure, or shock, and can even lead to cardiac arrest. In the field, your treatment for this condition is extremely limited, and what you're going to mainly do is maintain the patient's airway, provide adequate oxygen, and maintain their intravascular volume. You should also provide rapid transport to an emergency department that's capable of handling this patient. Fatty embolisms, on the other hand, happen when droplets of fat become lodged in the blood vessels of the lungs. This causes inflammation of those blood vessels and in other areas where those fats are deposited. Signs and symptoms typically begin within 12 to 72 hours of the injury and include things like a rapid heart rate, shortness of breath, rapid breathing, and a buildup of fluid in the lungs. The patient may also have a fever, petechiae or red spots of the skin, and a change in mental status, as well as beginning to develop some organ dysfunction syndrome. All right, so now let's talk about some specific fractures. Clavicle fractures are very common, especially in children, and are typically caused by a fall onto outstretched hands, or maybe even a direct trauma to that particular side of the body. Shoulder fractures, which involve the glenoid fossa of the scapula, the humeral head, or the humeral neck, usually occur in older patients as a result of a fall onto an outstretched hand. So depending on the age of the patient is where we would expect to see the particular types of fractures. Younger, we're going to see more of a clavicle. Older, we're going to see more of a shoulder, which is going to more probably involve something about the humerus. Scapula fractures typically result from violent direct trauma, and you should check for associated interthoracic injuries such as a pneumothorax, hemothorax, or even rib fractures whenever you suspect or you have an obvious scapula fracture. The signs and symptoms of a clavicle fracture are going to include pain in the shoulder, swelling, and an unwillingness to raise their arm. You might also see a patient tilting their head toward the injured side to reduce the tension, the muscle tension on that side. They're trying to shorten up those muscles and get a little bit of pain relief. Shoulder fracture signs and symptoms include swelling, bruising, and pain with any kind of movement of the arm. A scapula fracture, the signs and symptoms are going to include swelling and pain that gets worse when the arm is moved away from the body, which is known as abduction. Due to the location of the scapula, potential complications are going to include damage or injury to the axillary or brachial plexus, the axillary artery or brachial plexus nerves, maybe even a pulmonary contusion, or even a clavicle fracture might be kind of go along with that as well. You can actually treat shoulder fractures, and the best way to do that is with that sling and swath. Because of the high energy trauma that causes them, a suspected scapula fracture should be treated with full spinal immobilization because the likelihood of there being another injury, because it takes quite a bit of force to fracture a scapula. So you should always have a high index of suspicion for spinal injuries with scapula injuries. Midshaft humerus fractures are most often occur in younger patients and are caused by high energy injuries such as motor vehicle crashes. Signs and symptoms are going to include significant swelling, bruising, gross instability of the arm, and even maybe some crepitus. You should also be concerned about damage to the nerves and blood vessels in the upper arm, especially to the radial nerve. In order to manage these fractures, we're going to provide some longitudinal traction to help correct those angulations of those fractures. Stop applying any traction if the patient feels pain or if the pain becomes severe or their neurovascular status begins to worsen. Once the extremity is realigned, apply rigid splint and sling it if you can. Use cold packs to help reduce the patient's pain and potentially help with some swelling. Supracondylar fractures often occur in children as the result of a fall onto an outstretched hand with the elbow extended. The broken bone fragments can be pushed in different directions, compromising the brachial artery and the radial and median nerves. If the brachial artery is compromised, there is a risk of compartment syndrome beginning to develop in the forearm. Radial head fractures of the proximal radius occur from either a fall onto an outstretched hand or a direct blow to that area of the arm. Because of the risk of injury to nerves and blood vessels near the fracture site, you must perform a very careful neurovascular exam and use a lot of caution when splinting these patients. Signs and symptoms of a distal humerus fracture include swelling, bruising, and pain at the area of the elbow. The signs of a radial head fracture include significant pain with supination, or that rotating of the hand to the face, or pronation, or the rotating it face down, as well as bruising. You should repeatedly assess for compartment syndrome and only use cold packs if there is no evidence of compartment syndrome. You must conduct a neurovascular exam before splinting. You can proceed if the patient has a distal pulse, but if they don't, you must consult with the appropriate medical facility. However, they may ask you to begin to manipulate that to try to restore a pulse as well. Of course, then you want to make sure that you transport that patient urgently if you're not able to restore a pulse in that extremity. Forearm fractures can occur at the radius, the ulna, or maybe even both. They're typically caused by a direct blow, also known as a nightstick fracture, or a fall from an outstretched hand, which can cause what's known as a Colles fracture. These fractures are most common in elderly patients that also have osteoporosis. The signs and symptoms of a Colles fracture include pain, swelling, and a dorsally angulated deformity of the distal forearm, which is also known as a silver fork deformality. The treatment for forearm fractures includes splinting the entire forearm for stabilization. You should also apply cold packs to and perform frequent neurovascular exams, keeping an eye out for compartment syndrome. A scaphoid fracture happens when a person falls onto an outstretched hand, injuring the bone just below the radius. A major concern with this fracture is avascular necrosis or bone death due to the scaphoid's limited blood supply. You should splint the injured hand with the wrist placed in about 30 degrees of extension. A boxer's fracture, on the other hand, is a break in the neck of the fifth metacarpal, the bone of the small finger. It occurs after punching a hard object, and that's typically when we see that. Metacarpal shaft fractures can be caused by a crush injury or direct trauma. A mallet finger is also known as a baseball's fracture. Occurs when a finger is jammed into an object, resulting in a small piece of bone being pulled off by the extensor tendon. Signs and symptoms of a scaphoid fracture include pain and tenderness in the anatomic snuff box, which is the small triangular depression at the base of the thumb. The signs of a boxer's fracture, on the other hand, are noticeable swelling and pain over the ulnar aspect of the hand, which is the side closest to the little finger. Metacarpal fractures include pain. We'll see with metacarpal fractures, we'll see pain, tenderness, swelling to the palm, and abnormal rotation or alignment of the fingers. The sign of a mallet finger is the inability to straighten the distal phalanx or the last bone of the finger, which stays at a bent position. You should splint the injured hand in a position of function by securing it to an arm board or other rigid splint. You should also elevate the extremity to prevent swelling. In the case of penetrating injuries, be sure to apply bulky dressings and manage any bleeding that may be present. Pelvic fractures, on the other hand, are uncommon injuries, but they are responsible for a significant number of deaths in blunt trauma patients. The risk of death from these fractures can be as high as 55%. This is because the bleeding is caused by damage to the major arteries and vessels, Disruptions of the pelvic ring are caused by high energy trauma such as crush injuries and falls from significant heights. If a patient has a pelvic injury, you should always suspect that they have other serious injuries as well, known as musculoskeletal trauma. When the pelvis is fractured, several important structures are at risk for injury, including the bladder, urethra, rectum, vaginal area, and the sacral nerve plexus. The blood vessels most prone to damage in a pelvic fracture are the veins within the pelvis. The nerves at greatest risk are those in the lumbar sacral regions, including the sciatic and femoral nerves. Lateral compression injuries happen when a force impacts the side of the body. The side of the pelvis that took the impact rotates inward, which decreases the overall volume of the pelvic area. Because the volume decreases, there is a lower risk of hemorrhage with this type of injury. Anterior-posterior compression injuries happen as a result of head-on collisions or falls. The pelvis is compressed from front to back, which causes the ligaments to tear and the pelvic ring to spread open like a book, sometimes called an open book fracture. The risk of massive blood loss is high because the volume of the pelvis increases when it opens up. A vertical shear occurs when a major force is applied to the pelvis from above or below, causing one or both sides of the pelvis to be completely displaced. This can cause a fracture of the rami or a disruption of the pelvic symphysis, ilium, sacrum, or the sacroiliac joint. This type of injury results in an increased pelvic volume, which puts a patient at risk for massive hemorrhage. A straddle fracture, on the other hand, happens when a fall and a person lands on their perineum. Basically, legs go either side, which results in fractures of both the inferior and superior rami of the pelvis. This fracture does not interfere with the patient's ability to bear weight. However, the injury carries risk of complications, particularly to the lower genitourinary system. Open pelvic fractures can cause life-threatening bleeding because they often injure major blood vessels. These fractures can be caused by either penetrating or blunt trauma. They cause massive hemorrhage and have a mortality rate 5 to 16%. A frequent result of this type of fracture is chronic pain and permanent disability. The signs and symptoms of a stable pelvic injury include pain in the pelvis and difficulty bearing weight. In contrast, the signs and symptoms of a profound injury include profound shock, gross pelvic instability, and diffuse pain in the pelvis and lower abdomen. You may also see bruising or lacerations in the perineum, scrotum, or groin, as well as blood coming from the urethra, vagina, or even the rectum. Signs and symptoms of vertical shear include a significant shortening of the limb on the affected side and possible massive hemorrhage to the pelvis. Any bleeding seen in the area of the rectum should increase your index of suspicion for a pelvic fracture. The assessment process, of course, is going to be the same for all types of pelvic fractures. You should conduct that primary survey of the patient's mental status, ABCs, while also taking spinal precautions. Assess the pelvis for any bleeding, lacerations, bruising, or instability. A search for entry and exit wounds from penetrating injuries should not delay your transport decisions. The initial treatment for a pelvic fracture should include monitoring the patient's ABCs, spinal stabilization, and establishing IV access. The main goal in management is going to be reduced bleeding, which may include the application of a pelvic binder or tying a sheet firmly around the pelvis. To apply a pelvic binder, you must first log roll the patient onto a backboard and center the binder over the greater trochanters. Then use the Velcro straps to connect the two sides of the binder and apply gentle but firm pressure to close the pelvis, followed by a final tightening. Afterward, you must ensure that the patient can still breathe easily and that the binder is not impeding their breathing. You should provide rapid transport to the emergency department, administer IV fluids to maintain adequate blood flow to the tissues, but be careful not to give too much fluids because excessive fluids can worsen bleeding and disrupt the body's natural clotting process. All right, and that is part 2 where we finished up with pelvic fractures. We'll move on to the specific fractures and things that we'll deal with the lower extremities in part 3 before we round this thing out and finish up.